All right, Neoplasms, which is also in your Ricci text, chapter 46. We're going to specifically talk about osteosarcoma, Wilms tumor, brain tumor, Hodgkin's disease, and acute lymphoblastic leukemia. So osteosarcoma is the most common pediatric bone cancer. There are other bone cancers. This one's the most common. It arises in the bone or soft tissue. It can be in both. Tends to be in the soft tissue in smaller, younger children, and the long bones in the adolescent. The risk factors are being a male of African American or Hispanic descent and being an adolescent. The cues, bone fractures that are kind of unexpected. We don't expect to see a femur or a radial fracture as an adolescent, even as a school-age child. Limp, limited range of motion, and erythema or swelling of the limb. So none of these has to happen independently of each other. They can all happen at the same time, or they can be just one cue here and there. The diagnostics and labs we do to prove osteosarcoma is bone scans, MRIs, CTs, and X-rays. And then it is managed by giving chemotherapy that's used to basically debulk or shrink the tumor down so that it is easier to remove surgically. And then they can do surgery to remove it. Sometimes they have to amputate limbs completely, and then after the surgery has been performed, they give more chemotherapy to prevent recurrence and to treat for any metastasis. The complications of osteosarcoma are metastasis to the lungs and other bones, and it does tend to recur after induction chemotherapy and surgery. It recurs in the lungs. The actions and interventions are going to be to control pain. They're going to have preoperative pain, postoperative pain, and pain caused by the effects of chemotherapy. We want to try to control all of the side effects and adverse effects of chemotherapy for the child or teenager. We're going to monitor them pre and post-operatively for infection, bleeding, pain, and then we need to provide really good emotional support. The teenager and the older school-age child are going to be acutely aware of the changes in their body image because they are likely going to have a large surgical scar, if not the removal of a limb or partial removal of a limb. They could potentially and are likely to lose their hair due to the chemotherapy, and they just kind of look sickly overall. So body image can be a huge issue that we need to try to provide support for. And telling someone, oh no, you're beautiful just the way you are, is not emotional support for body image. It's allowing the therapeutic communication, which most of the time means the nurse has to be quiet, ask leading questions that are open-ended, and allow them to express their discomfort and unhappiness. And then try to give them some coping mechanisms. It's not always easy. We want to emotionally support the family because they're going to have altered functioning as well as the child. They're going to be spending a lot of time away from work, away from their other children, and potentially away from their spouse or partner, and it's going to cause a lot of issues. Fatigue and a severe extreme emotional distress combined with um, lack of sleep and um, uncertainty, all those things just lead themselves to cause more problems than it's worth. And then obviously we have to provide emotional support to the child and the family related to mortality, because the parents of the child and the caregivers and the loved ones are all going to be concerned with the potential loss of the childhood, the functioning, and potentially the complete loss of their child. And then the child themselves is going to be, depending upon their age, fearful of the unknown, kind of apathetic about even participating in things that make them happy because they might be pre-grieving their loss of life. That anticipatory grieving really can take a toll, and we have to be willing to have the conversations with the child and the family related to their mortality and what their wants and desires are and how they would like things to be handled. All right, Wilms tumors. A Wilms tumor is the most common renal tumor, and it's the second most common abdominal tumor in children. So it doesn't really have a known etiology, but they do see it occurring with some genetic factors. It grows super, super fast and it spreads through the bloodstream because kidneys, they help to filter our blood. So if something's wrong inside the beans, it can spread all through the blood system. The risk, basically, they can have the prognostic indicators are that it's actually really good. There's a survival rate of upwards of 90%, but that's if when they remove the tumor or the kidney, the histology or histologic examination of that organ shows a favorable histology. There's certain markers they look for, and if the markers are there, they think, okay, good, child is probably not going to have any issues with survivability. But then there are unfavorable histologic markers, and those do not have a good prognosis, but they are exceedingly rare. The risk factors are being 2 to 5 years of age, having something called hemihypertrophy. If you ever see a child that one side of their body is larger than the other side, like visibly larger, one leg is larger, one arm is larger, it's a good possibility that the kidney on that side could be involved with a Wilms tumor. There's also some syndromes that basically, there's one called Beckwith-Wiedemann syndrome, and it makes embryonal cell growth happen very rapidly. If a child is born with any genitourinary anomalies, interestingly enough, they have found a child with no iris in their eye, that is a precursor or a risk factor for developing a Wilms tumor, and we need to look into them. Being African American and having a family history of cancer, those are also risk factors. The cues that we have noted here, normally a child with Wilms tumor doesn't have all of the pain and possible cues that are listed here. If it's caught relatively early, the only thing we might see, because it's rapidly growing, is a large one-sided abdominal mass that we see when we're changing their clothes or bathing them. And because this is a younger child, 2 to 5 years, we're usually the ones doing all the bathing and the clothing and removing clothing and all that stuff. When parents see that abnormal swelling on one side of the abdomen, the mass is usually solid and painless. They'll bring them into the doctor, examinations done, and they are diagnosed with Wilms. It is possible that they could have fever, constipation, vomiting, anorexia, weight loss, and difficulty breathing. The difficulty breathing is because the kidney might be swollen and pressing on the diaphragm. So the diagnostics and labs that we do for Wilms tumor is renal and abdominal ultrasounds, CT and MRI. We'll look at the CBC to see how the white count is, and also how the red blood cells, hemoglobin, and hematocrit are, because the kidneys deal with our blood filtration. BUN and creatinine might be a little elevated. We're going to do a UA and or a 24-hour urine collection. And then the management of these children has to be a nephrectomy. We have to remove the involved kidney, and then they have radiation or chemotherapy, possibly both, depending on whether it's a favorable or an unfavorable prognosis. Okay, so the nursing actions and interventions, we have to put a sign above the bed in the patient's room that says never, ever, ever palpate their abdomen. So their abdomen might be palpated the very first examination that is done by the doctor when the parents brought them in. But at the point that we expect or suspect Wilms tumor, we never press on their abdomen or flank again, because doing that can do what is called tumor seeding. And basically we would smush the tumor and it would seed tumor cells into the bloodstream and cause metastasis if there isn't any yet. And we don't want to do that. So we ask parents not to pick their kids up under the arms. We want them picked up kind of like in a, a honeymoon pose, like crossing the threshold, where you pick somebody up in your arms with their legs over one of your arms and your arm around their back, not just under the armpits. We provide post-op care for these kids, and we are watching constantly for the monitoring and maintaining the remaining kidney function. So whatever kidney is left over, we have to be very specific about making sure that it's working. And we provide a lot of education on renal hygiene, sexual hygiene, and hydration, and that the patient needs to not have any contact sports, because they're only going to have one kidney and we don't want to lose it. The complications of a Wilms tumor is metastasis, potentially liver or renal damage, female sterility because of the chemotherapy that's used, bowel obstructions, pneumonia, and scoliosis because of the pressure that it can put on the abdomen and the spine. It can twist us a little bit. So the NCLEX pearl here is Wilms tumor, we don't palpate the abdomen. Absolutely not. Okay, brain tumors. So brain tumors are the most common solid tumor and the second most common type of cancer in children. More than half of the brain tumors are located in the posterior fossa. The most common type is called a medulloblastoma, and it's found in the cerebellum. It's not great because it is highly invasive and highly malignant. Um, they can develop brainstem herniation, hydrocephalus, increased ICP. It's really kind of not great. So though the cause of brain tumors is mainly unknown, the effects of the tumors are pretty predictable. So they might not know why it's happening, but they know what's gonna happen once it's there. The tumor growth happens really quickly. It puts pressure on the tissues. As it exerts the pressure on the tissues, then it might start compressing structures that are vital for function. It might block the cerebrospinal fluid. It might cause edema in the brain. It's going to cause increased intracranial pressure. And then we're going to have presenting symptoms that vary according to where the tumor is in the brain and what type of tumor it is. The risk factors are being 5 to 10 years old and having a history of neurofibromatosis or a history of central nervous system leukemia. But it can happen outside of these risk factors as well. The cues are that we're basically going to see all the same things that we would see with increased ICP. Nausea, vomiting, headache, they're going to have an unsteady or ataxic gait, possibly blurred or double vision, seizures can occur, they might have abnormal motor function or be completely weak or paralyzed on one side, difficulty swallowing, they might have behavioral or personality changes, that it was a really nice child who listened and was very intelligent and liked to please, and then all of a sudden they're angry and combative and say hateful things, and that can literally just be because of where the tumor is pressing. Irritability is common, failure to thrive, and developmental delay. So the diagnostics and labs that we do are CT, MRI, PET scan, and a lumbar puncture. We might not do every single one of these, but we need to do at least 2. We'd probably do a lumbar puncture regardless, and then choose which scan is going to give us the best visualization. The management of these kids is going to be placement of a VP shunt if hydrocephalus is causing so many problems that they cannot wait for radiation or chemotherapy to occur. Radiation can only be given if they are older than 3 years old, and chemotherapy can be given to any age. The actions and the interventions that the nurse is going to do is to be monitoring for increased intracranial pressure and the symptoms related to that. And we're going to be providing pre and post-op care if they had a VP shunt. We're also going to be monitoring for signs and symptoms of infection and any adverse effects or side effects from radiation or chemotherapy. The complications that these kids could have is hydrocephalus, increased ICP, their brainstem can herniate, which will cause death, and they could also develop endocrinologic issues related to their pituitary. All right, Hodgkin's lymphoma. So the pathology on Hodgkin's is kind of unknown. Most of the cancers are unknown. They do believe that there could be some possibility that it's virally mediated, meaning that they've had a virus that they were exposed to. It caused their system to go a little nutty, and they created Hodgkin's. The risk factors are being male and adolescent, having potentially HIV, genetic or immune disorders, and or a family history of Hodgkin's disease. The cues are weight loss, fever, night sweats, and these are severe night sweats. Like not just like a little sweaty in the middle of the night. They wake up drenched. Cervical or axillary masses because it's in the lymph and the lymph nodes. Anorexia, malaise, fatigue, itching, and a recent exposure to a viral illness that was pretty severe. The diagnostics and labs we do for Hodgkin's are CBC, tissue samples, chest x-ray, and CT and MRI. And then we'll start them on chemo and or radiation. And if they go into remission and then relapse, I believe it's after the second relapse, they can have a stem cell transplant. And then we go from there. The actions and interventions that we do as the bedside nurse is we're managing the side effects, again, of the chemo and radiation. We're monitoring for any central nervous system involvement, and we're monitoring their respiratory effort. We also want to, if they've had a stem cell transplant, we need to monitor them for the possibility of graft versus host disease. So the very first thing that we see with graft versus host disease is a rash. So we want to watch for that rash and make sure to let the family know what they need to be watching for as well, so that we can get the child in as soon as a reaction might be happening to the stem cell transplant. And the complications of Hodgkin's lymphoma are liver failure and development of secondary cancers. So the treatments that we use for Hodgkin's lymphoma, the chemos, they can frequently cause other sorts of cancers to happen, and vice versa. Depending on if you use biologics or I think they're called DMARDs, disease-modifying anti-rheumatic drugs. Like I've taken them. You can develop Hodgkin's later on. And then if you have Hodgkin's and you take those things, you can develop rheumatic issues later or other types of cancers. All right, acute lymphoblastic leukemia, or ALL. This is cancer of the bone marrow, and it is the most common form of cancer overall in children. The cure rate is 70%, which is great. But that's based on how high the white blood cell count is at diagnosis. If when they're diagnosed, their white blood cell count is crazy high, the prognosis is not as good. So the pathology of acute lymphoblastic leukemia is that the bone marrow starts spitting out abnormal or immature white blood cells, and this prevents the growth of red blood cells, platelets, and normal white blood cells. They believe that some chromosomal anomalies or genetic issues could play a part in developing this, but they're just not completely sure. There's so many lymphoblasts just kind of hanging around and being the predominant cell in acute lymphoblastic leukemia. And lymphoblasts are like preschoolers. They're immature and they're weak. They can't fight. So they don't fight infections as well as mature lymphocytes. So if there's too many lymphoblasts, they're allowing for infection to occur, and then they're also taking all of the nutrition and nutrients from the rest of the cells that are trying so hard to grow. The risk factors are being Caucasian, 2 to 10 years old, male, having genetic syndromes, having siblings with leukemia, and having been exposed to radiation or chemotherapy in some other form or treating some other disease. The cues are the kid starts having unexplained fevers, bruising, petechia, night sweats. They're going to get pale, have fatigue, shortness of breath, decreased appetite, and lots of bony and joint pain. They just feel really puny. And it's usually they're brought in because they're developing infections that aren't going away. So the diagnostics and labs we're going to see, we expect to see a low hemoglobin and hematocrit, low red blood cells, low platelets. We don't really have an expectation of the WBCs. They could be elevated or they could be decreased, but what we will see is lots of blasts in the peripheral smear. And then we do a bone marrow biopsy or aspirate, and that's going to show us at least 25% lymphoblasts. And we're like, oh, okay. And then we do a lumbar puncture and we see similar things. So most of the time with leukemias, it is expected based off of a basic laboratory profile and the physical examination of the child. The doctor will tell the parents that leukemia is what they are suspecting, and then they will do the bone marrow biopsy and lumbar puncture diagnostically, and it's just a horrible time. The families are so stressed out, just kind of being in limbo and not knowing. So after they find out, we give chemotherapy. So even though there's a 70% cure rate with ALL, getting there is so difficult. The kids are going to spend at least 1 year inpatient receiving treatment. And then after 1 year of constant inpatient chemotherapy and radiation therapy, then they might get to be outpatient, but those visits are really frequent. It's a lot. And those happen for at least another year to 2 years. So it's going to take us anywhere from 3 to 4 years to really treat a child with ALL and watch them go into remission. So getting them there, we make them really sick for a really long time, and their family is stuck in the hospital for at least a year. It's just so stressful. Yeah. So hematopoietic stem cell transplants can be done. Those aren't always the first avenue of treatment that we use. So actions and interventions as the bedside nurse. We are needing to prevent infection. So in order to prevent infections, we have to make sure that their immunization status is kept up to date. Chickenpox infection, and this is a hint, in a kid with leukemia can lead to a really bad outcome. So we definitely don't want them to get chickenpox. If we can give them or get them as close to up to date with all of their immunizations before they start induction chemotherapy, better. We need family members to all be up to date with their immunization status as well. We want to prevent bleeding overall because they're going to have thrombocytopenia. So we're not going to do IM injections, sub-Q injections, or rectal temperatures for any child that has thrombocytopenia. We're going to use the least invasive route for administering meds. So if we can get like a portacath in place. We will use it for drawing blood. We will use it for administering medications, fluids, chemotherapy. Same thing with a PICC line. If the patient comes in and needs to be hospitalized for close to a year, like, they all do, we will educate them as best we can on the need for the portacath placement. IMLA cream, if you don't know what that is, it's like eutetic something or other, lidocaine something. It basically means we're slapping lidocaine cream all over your skin so that it doesn't hurt as much when we do the port access, bone marrow aspirates, lumbar punctures. We basically want to do like IMLA cream for 30 minutes to an hour prior to accessing the port, but there's also lidocaine that sprays, and those are really great for port access. If they're going to have a lumbar puncture or a bone marrow biopsy, we want the parents at home to put the IMLA cream on, and it is a prescription from the pharmacy. So if they're doing it, we want them at home to do the IMLA cream 1 to 3 hours prior to coming in for the bone marrow aspirate or lumbar puncture. And we want to try to maintain and manage pain and trauma. So they're going to have peripheral neuropathy, headaches, abdominal pain, neck pain, leg pain, and nausea and vomiting, all due to chemotherapy. So we're going to provide them with analgesics and pain meds, hot and cold compresses depending on what they want, narcotics as needed, distraction. We use our child life specialists for children with ALL that are in the hospital for chemotherapy so much because they are just wizards at distraction techniques, making sure that they can get up out of their room and come to the playroom and do puzzles and arts and crafts and interact with other children. We do have to manage infection and anemia and bleeding. We always give, if we're doing a transfusion, it has to be irradiated CMV negative leukodepleted blood. You don't have to necessarily remember all that, just know. We don't want to give them any more leukocytes or lymphoblasts or any of the white blood cells that they don't need them. Don't give them to them. So make sure there's nothing in their blood, in the blood transfusion that we're giving. Some of the complications these kids are going to deal with is infection, hemorrhage, delayed growth and development. They're going to have delayed development for sure because they're hospitalized, and that prevents them from being able to run and jump and play and interact and develop all of those social and physical skills that are necessary for next steps of development. They can develop central nervous system, bony or testicular involvement. So we want to watch for any of those cues like level of consciousness changes, seizures, severe lethargy. If we see any of that, we want the parents and the nurse to report it immediately to the oncologist. New joint and bone pain, we want to report. New headache, vomiting, seizures, and coma. And it's frequent that one of the complications is different cranial nerve palsies and visual like problems and changes that might never go away.